Good morning. As people are coming in, we're going to go ahead and get started because we have a lot to cover and a tight schedule and some very busy electeds who are sharing their time with us and have hearings to get back to. So thank you all for coming today. I'm Dr. Danielle Green, Executive Director for State and Local Public Health Initiatives, and I'm pleased to welcome you to the CUNY Graduate School of Public Health and Health Policy. We are live casting this morning's event. So please be aware that if you talk to your neighbor, then mics will pick it up and everybody listening on Zoom will hear your conversation. So let's try to keep room noise down. We have refreshments in the back and the bathrooms are behind me when you go out in the hall. For audience Q&A, we will be taking questions from the audience and the remote audience in writing. So there were cards and pens on the table as you came in. If you didn't get one, raise your hand and we will bring it to you. And now I would like you to join me in welcoming our beloved Dean, Dr. Ayman El-Mohandes, who will be giving opening remarks and moderating the panel.
Good morning, everybody. And I hope this is carrying well. I have a little mic on my eye. I hope you all hear me. It's a great pleasure to have this grand rounds as part of the activities of the Pandemic Response Institute. Today, we are having a special welcome to a group of esteemed panelists that are going to join us momentarily and whom I will introduce shortly. Our public health workforce is at a crisis point, as is our budget. I hope today we will move us towards a much needed action plan that addresses both fiscal and non-fiscal strategies for a solution. On our second slide, please, and I think Michelle is helping me move the slide forward. We are surrounded by threats to our health from food, water, airspace, and activities that we participate in on a daily basis. The role of public health is to prevent these threats from injuring or making us sick and to maintain our community's well-being. Public health is a unique discipline and field that uses training, science, evidence data, and community input. I think I'd best talk into that mic to maintain our community's well-being. You can find public health at the intersection of social, environmental, physical, mental health, and economic influences. When housing is in short supply, social services are cut back, and the economy is in recession, people and entire communities end up in situations that are detrimental to their health. Increasing demands for public health and public services, just as these resources dwindle. A paradox that we all are sometimes confronted with. On the next slide, local and health departments, data on public health workforce in the United States and New York. The map shows that population growth drives the demand for public health services. And yet, as the US population grew by 8% between 2010 and 2019, the health department workforce across the nation decreased by 17%, the opposite of what we would have expected or needed. While the public health workforce is everywhere, we only have data on governmental public health workforce. But the data that we have shows us that we need to hire at least 80,000 new public health department professionals nationally in order to provide the most basic public health services right now. The data also tells us that 1 in 3 health department employees that have been surveyed are considering leaving their organizations within the next year due to job dissatisfaction, burnout, or reaching retirement age. This will create an additional shortage of approximately 130,000 workers by 2025, a very alarming number, or a cumulative deficit that reaches almost 200,000. Just in state and local health departments. Locally, data from New York State Association of County and Health Officials show that the overall health department vacancy rate is nearly 20%. And that goes across the board with some counties up to 30% deficit, which is really somewhat alarming. Next slide, Michelle. Influx of short-term funding are recurring and has been a recurring trend, as you see from the top line of this slide. We have been confronted with a myriad of challenges over the past decade, each of which is accompanied with an infusion of capital, but once the crisis is over, the funding disappears, often not even leaving enough for ongoing prevention efforts, a cycle of panic and neglect, which we have experienced over and over, most recently during the COVID pandemic. Remember that local health departments are responsible by statute to provide core public health services and conduct enforcement of public health laws, such as preventing underage sales of tobacco, holding landlords accountable for lead and mold or pests in properties, etc. These functions do not disappear during a time of crisis, and these departments are required to maintain their services in the broadest sense while dealing with emergencies. In my own study comparing COVID vaccination attitudes between New York City and the United States overall, we found that COVID fatigue dulled many Americans' attention to new information about the disease, although New Yorkers had a high willingness about and support of the initial vaccination. As their attention to new information dwindled, so did their acceptance of booster doses. And as such, we understand that continuing health communications in an effective and meaningful manner is essential to maintain protection in the long run. There is no question that the emerging viral and environmental threats continue to grow stronger and become more frequent while our workforce is shrinking. This slide is at best speculative, but demonstrates the decline of funding as the end of COVID funding disappeared. And how do we solve these challenges? How can we solve these challenges? We need to look towards sustained investment in public health infrastructure, pipelines to grow a trained and diverse workforce, and policies that recognize public health as an integral part of the structure that keeps populations safe. I would now like to introduce our panelists, and unfortunately, Karines Reyes is held in the Dominican Republic. She is not able to join us today, but on our panel, we have State Senator Gustavo Rivera. Welcome here, Gustavo, and we are so happy to have you with us today. Please take your seat. He has represented the 33rd Senate District in the Bronx since 2010. As the chair of the New York State Senate's Health Committee, Senator Rivera's goal is to collaborate with his colleagues, stakeholders, and constituents to improve health outcomes, increase access to coverage, and ensure a financially viable system for the 20 million New Yorkers he proudly serves. We also have, very proudly, Assemblymember Amy Paulin. Please join the panel. She has served the 88th New York State Assembly District since 2001. She chairs the Assembly Committee on Health and serves on the Committee on Rules and Education. City Council member Eric Dinowitz, thank you for joining the School of Public Health community today, and we hope you will become a regular visitor and friend to our school. Represents City Council District 11 in the Bronx, and he is a community activist former special education teacher and chapter leader for the United Federation of Teachers, and former aging chair of Bronx Community Board 8. He chairs the Committee on Higher Education. And as you can imagine from my introductory remarks, we will be talking about the pipeline and certainly the preparation of the next generation of our workforce. Jan Dorman, you are with us on the screen. I see your name and you will probably turn your video on. But he is joining us remotely today. Jan, good morning. And he is the director of the Senate Higher Education Committee, chaired by State Senator Toby Ann Stavisky. Welcome to all of you. And I will join the panel, and I will start by asking our panelists second here. I stomped my toe, so I'm hobbling away a little bit today. Your mic's working? No. We can share.
Well, the little battery.
Michelle, can you help us before we start? I think, yes, I can share mine with you.
That's right. I'm just trying to explain the little picture of the battery. This is why we need more career and technical education.
Exactly.
Schools.
Yeah, this is.
So we'll share.
With a picture of the battery.
Thank you. And I would like to start by asking each of you to share the notable public health workforce challenges as you see them and as we are experiencing in the post-COVID era. What have you observed and what are your thoughts on solutions? And can we start in order? So I'll hand you my mic.
Thank you. We like sharing in CUNY, sharing resources, save a couple bucks. As was mentioned, I'm Eric Dinowitz, council member in the Bronx and educator. When the pandemic hit, I was in the classroom. And by the way, it was that time where teachers still had to go into school, but everyone else didn't have to go into school. There were no cars on the road. It was an incredible sight. But then we started teaching remotely. And I had students whose family members got sick. I had parents who were remote parenting because they were nurses or doctors, and we didn't know anything about COVID at the time, just to stay away from those you loved for fear of getting them sick. So of course, emotionally, it was a challenging time, but we saw communities like those in the Bronx get hard hit. We were wholly unprepared. There were, the stories of the bodies in the trucks outside, people in the hospitals, severe understaffing was a crisis. And that's what we saw immediately. But we also saw that those in communities with pre-existing health conditions, like pulmonary issues with the lungs, were hit the hardest. And it didn't take long for people, not doctors like me, regular run-of-the-mill teachers, for me to see that those students, the number one reason my students were absent was asthma throughout my 13 and a half years of teaching. And those were the students, or those were the communities where we saw the greatest impact of COVID-19. So we saw staffing challenges, we saw pre-existing health conditions impact our ability to address the pandemic and also to be resilient and prepared for it.
Absolutely. And as such, what would you have thought could have been helpful at this very early stage in terms of preparedness from the public health workforce as a teacher in the school system within your neighborhoods and communities?
So I think to say, what would you have done on March 16th, March 17th is really tough. I had said proposals about remote learning, how we could have handled that and prepared our teachers and students and families better. But I think the work needed to have happened years and years and years ago. We see severe underinvestment in places like the Bronx, things like green space, things like environmental and health education. I had students who would, high school students, I taught high school, for breakfast would bring Doritos. And I saw your face. It is that gross. They would bring Doritos and Coke, and part of it's education, part of it's, oh, it's food, and part of it is access to food, to healthy food, to affordable food. I was very fortunate, and I'm sure we'll have a chance later to talk about high stakes tests, but skipping over that, I was fortunate to teach a class that didn't involve a high stakes test, environmental science classes. I was fortunate to be in a big school that had a beautiful garden, and I would take my self-contained class to the garden very often. We would plant fruits and vegetables and herbs, and then they would grow. And then I remember taking the cherry tomato off the vine, and some of the students would say, "Ew, Mr. Dinowitz, what are you doing? That's disgusting. What is that?" I said, "Well, where do you think your food comes from?" And it was sort of this weird aha moment that at 15, 16 years old, they were just discovering. And then some of them started reluctantly, but eventually taking the tomato, taking the raspberry, trying the sorrel, trying oregano, trying all these different things they wouldn't have otherwise tried, usually enjoying them. And eventually, in many cases, they wouldn't take the Doritos to school anymore. They wouldn't take the Pepsi. They would take, no one drank Pepsi, it was Coke. Who drinks Pepsi? They would bring an apple or an orange. They would, because they experienced food and grew the food themselves. They had a personal connection with food. They understood what it means to eat healthy, and they started eating healthier. And that's one of the seemingly small things that impacts the child's life. But if you think about the long-term impacts, imagine a child or the children who are eating apples and carrots instead of Doritos and pretzels, what that means for obesity and diabetes, what it means to have students who are stewards of the environment, who know how to plant things and plant trees, what that means for the long-term, for their long-term results in asthma, that you have more trees and students who care more about that. And so we really have to be looking, have a little more forethought and know that there's going to be a health crisis. And the people and the communities that are going to be the most resistant and the most resilient are the ones who are the healthiest, are the ones who have been taught from an early age and been supported from an early age to eat in ways we know produce positive long-term outcomes, and are, again, stewards of their environment, that live in communities with green space, that they aren't developing asthma at a very young age.
Thank you. Now, Assembly Member Amy Paulin, you're very directly involved in that very critical moment. And we're thinking back on the challenges as the pandemic started. Where do you think we had deficiencies and gaps, especially in the workforce? And what solutions do you propose for us not to fall into that same pitfall?
Well, hopefully we don't see another pandemic soon. And I don't know if there's a way to adequately prepare for what we encountered. I do want to talk a little bit about workforce, because I think it's more than the public health community. It is the entire healthcare sector, and it's broader than just New York and the United States. We're seeing a workforce shortage internationally in every area of healthcare, from physicians to public health workers to nurses, everywhere. So the question is why, and the question is, what do we do about it? And as a school, I found myself, when thinking about it, asking questions. Are you seeing a diminution in number of students enrolling? Are you seeing those students that are graduating getting jobs? Are you seeing those students turn away from the field after they've graduated because of X, Y, and Z? So I think it actually starts here for us to begin to understand, what is problematic out there. And I don't know that it's going to be different in public health than it is in other areas. I think there was a lot of burnout due to COVID, and perhaps more consideration to getting into the health field. Also, health generally, physicians included, used to make a lot more money proportionate to what everybody else was making. And I think that has changed. And I honestly don't think it's going back. So what does that mean going forward? Does there need to be more regulation universally? Right now we negotiate through unions, but we also see a lot of stealing. Nursing homes are complaining that hospitals are stealing all their nurses, and they are, because they can. So, and there's also a funding element. So, at the state level, we fund, I don't know, I'm going to make this up, 35 to 40% of health departments across the state, some percentage, most very small areas, the health department is run by the state. In other areas, like where I live and in New York City, you have your own health commissioner, you have your own department. And what drives a lot of that funding is local, is the understanding that, perhaps the health department is misunderstood. And I think there was a lot of that, perhaps at the city level and in my county. What did they do? And they were easy to cut. Property taxes, drives a lot of the suburban agencies, for example. New York City, I think it's less so, but probably somewhat. So are there, a lack of respect, perhaps, or a lack of understanding of what the department does? At the state level, I think that there is a better understanding, but still a drive. What are they doing out there? What do they really do? What does public health really do? And, and I think we learned a lot, which actually during COVID, I don't know whether that helped or hurt, but we learned a lot about what public health can do and should do. But there's still, people understand what a physician does. They understand what a nurse does, a nurse practitioner, maybe not a physician assistant, but so there's some sectors that, there's public understanding and not. But what does a public health worker do? So again, I come back to the school. Are you seeing less students enroll? Are you seeing those same students not getting jobs? Are you seeing them turn away after they've graduated? What are you seeing? Because you are the beginning of that process that, that filters into the remaining. And without that knowledge, I don't know that I can help you.
Absolutely right. You're touching upon very important elements, Assemblymember Paulin, and I'd like to ask Senator Rivera. We just conducted an international study, an international consensus study with more than almost 400 authors from 112 countries. And one of the consensus elements was that in order for us to confront challenges like COVID, we need a whole society and a whole government approach. Believe it or not, we thought that this was something we were struggling with alone, but it's a global issue. And, we just talked about the fact of lack of awareness of perhaps government officials of what role public health plays or what is the importance of public health. And you play that very important role. You are the voice of health and public health within an environment that may not necessarily always prioritize public health needs or the public health role. How do you envision the future? Do you see the needle moving? Are government officials more aware? Do you see that the legislation has a fatigue post-COVID, or are they willing to look forwards in terms of taking seriously the role that public health plays within government agencies?
Thank you for asking basic, simple questions, sir. Yeah, you give me that one. All right.
Yeah.
I would say that certainly many of my colleagues are aware of the difficulties in our current system. However, I think that we're kind of stuck in a way of thinking about things that makes it so it's harder to change, and I'll explain. One of the things that I'm focused on mostly is the fact that we have in the case of the United States of America, healthcare is seen as a commodity, and it is not seen as a right. Now, people might say, I believe that healthcare is a right, but we haven't designed policies that actually respond to that.
Mhm.
And so when you even in places where there are difficulties, and certainly because we are humans, and regardless of where we are, whether we're here or the Netherlands or Japan or wherever, no system is going to be perfect. But certainly the notion that during the height of COVID in Taiwan, you could walk into a clinic, get tested, and if you were positive, you were immediately told that you were going to have a place to stay. Your family was informed, but you had a place to go to be monitored, and while you were quarantined, and these things were just a natural extension of the fact that you have a healthcare system that is single payer in a sense, which is something that we do not have in the United States of America. So the notion that healthcare is a commodity, that it is something to make money off of, as opposed to a human right that we have to build policies to secure, is incredibly difficult to break, particularly because regardless of what we believe as legislators, and many of us, certainly I'll only speak for myself, but I'm pretty sure that the folks here on the stage would agree with these general notions. We are surrounded by many interests whose profit margin depends on us continuing to think of a system as not something that should be built as a secure right, but something that should be built to maximize profit for insurance companies or pharmaceutical companies, et cetera, et cetera, et cetera. So I would say that yes, there many of my colleagues certainly believe that that we need to move in that direction, and we need to redesign parts of the system, and hopefully I would argue and hopefully some of my colleagues would agree with me, fundamentally break some parts of those systems and rebuild them. But we're fighting against many entrenched interests that are resisting these things.
Absolutely. Now, we continue to talk about health and healthcare as a continuum, but in effect, most of the public health services are offered by government entities and not necessarily for-profit entities. And I would challenge a little bit that within the
Let's go, bro. Let's go. Come on.
Yeah. I would say that within the public health arena, we are hoping to energize government systems and support them to perform these functions because we're not as dependent on the private sector as we are in public health. So how do we view public health differently from the healthcare system in general?
I don't disagree with you. I think that certainly there are parts of it that we have taken on in government, responsibilities that we've taken on in government, precisely because they are not profitable.
Correct.
And then those are the things that we're trying to make sure that we do to keep people healthy. But the problem is that if we have to take care of a population whose sickness is seen as a potential profit by folks that are outside of that system, then outside of a governmental structure, then we're kind of in between a rock and three hard places. You know what I mean?
I see.
But I certainly would agree that governmental structures, the governmental entities, public health departments, and such, academic institutions, et cetera, certainly serve an incredibly important role. I'm a big believer in public entities. I'm a CUNY product and a public school product from back in a public university product back in Puerto Rico before I got here. And here I came to the CUNY Graduate Center. You'll notice that he did not introduce me as a doctor or a PhD, so that tells you how far I got. But it's still, and I'm obviously still connected to the CUNY system and a big believer in it. So I'm a big believer in public institutions and how they should ultimately be utilized to secure what is a right for people. And certainly public health is a right, and we should do everything we can to secure it.
We are also very connected to you, sir. So it's a mutual feeling. Mr. Dorman, I don't want to let it go without also addressing that question to you, perhaps from a futuristic point of view regarding the workforce and the preparation of the workforce in the future, which may, as I presented in my early comments, become the greatest challenge in the future of the public health services in our city, in our state, and perhaps nationally.
Well, thank you. I really am representing Senator Tobian Stavisky, who is chair of the Senate Higher Education Committee. Our committee reviews and develops legislation addressing post-secondary education in New York State. We deal with scholarships and opportunity programs for students, and we follow legislation for the licensed professions under Title VIII of the education law. So let's take a look at some of the numbers that we're aware of in New York. We have 6 schools of public health in New York State, the most of any state in the country. We have 41 institutions of higher learning that provide a public health program, public and private institutions, and 39 institutions that have nursing programs. So if you're looking at the gross numbers, you have to raise the question, is there a shortage in public health field? What we don't know, and this is an issue that we have to address, is we don't know how many students graduate from the programs, where the students go, what the workforce looks like in New York State. The last time we had an analysis of the public health workforce was in 2007 and 2008, when there was the task force that was put together in 2006 to do a roadmap. So we have 16 years of without current information as far as where the public health workforce is in New York State. So again, from our perspective, if you had not asked the Senate Higher Education Committee chair to participate, and we were strictly looking at the educational components that exist within New York State, we can't really talk about a shortage. The question really is where those graduates go, how many stay in the field, and that's really not within our jurisdiction as a committee. I think that is something that it's the data that we're really looking for. We are very much concerned about the health workforce in New York, but we really don't have current data to be able to make good decisions upon what choices the state should be making, where we allocate our resources, how we entice students to stay within public health as opposed to staying within the healthcare system in general.
These are very pertinent comments, and we know that much of what I described earlier, the burnout, the retirement, and so on, is in the public sector. And obviously, your question is well taken. We, as a public school of public health, try our level best to follow our graduates after they graduate, and our hope is by offering an affordable degree in public health, very high quality, I must say, but also affordable degree in public health, we offer them the opportunity of participating in the public sector more readily because they graduate with minimal debt compared to a degree in a private sector entity where they are sometimes left with a debt of $100,000 with a degree in public health. In our case, it's much more affordable, and we hope that one of the major contributions of public schools of public health should be infusing our graduates into the public sector. 2 things come to mind. Thank you very much for your comment. 2 things come to mind. One is that at the current moment, 54% of the public health workforce and more than 60% is white. And most of those that occupy leadership roles are white males. And we are seeing a disparity in women graduates in public health attaining the same levels of leadership eventually in public health, in the public health workforce, and the diversity in the public health workforce. One of the elements that we have seen is, for example, a proposal given to the federal government to have a loan forgiveness, for example, for people graduating with nursing degrees and medical degrees, but we have not been successful in promoting anything similar for public health graduates. So it's a dual question. How do you encourage, you as an educator, even in high school, how do you inspire your students, especially those with a diverse background, of understanding a career in public health and the importance of pursuing such a career? And then what incentives can you think of that are attainable in making public health careers more equitable, more diverse, but also encouraging graduates by things like loan forgiveness, for example, in seeing a future in the public sector? So it's a mixed question, but I know you can coordinate amongst yourselves.
We're a good team up here and back there too. He can't see me gesturing to him. You said a very important word, which is not spoken enough in the realm of education. It's that word and a second word. And these two words are extremely important. They drive everything students, teachers, principals do in the field of education. It's incentives and it's assessments. And surrounding all of that is all the different way our school system is structured. You give me a lot of credit to say I inspire my students. It's very nice of you. And if any of them were ever inspired by my teaching, that would be wonderful. And I could say when I taught living environment, when I taught biology, I tried very hard to make it engaging and exciting. And if there's any pedagogues in the room, I'd love to talk to you afterwards about how we do that. But here's the problem. What are we using to assess our students for living environments, life sciences? It's a single high stakes Regents exam. So no matter how exciting I would make the class, I knew and the students knew at the end of the year, they had to pass a single exam. And the real only thing the principals generally care about is that end of year test score. Why? Because the superintendents care about it. Why? Because the chancellor cares about it. They care about things they can quantify. And so until we start assessing based on things that actually matter, we're going to have a hard time inspiring our students and encouraging them to do anything of value in the public health sector. And by the way, I taught in the Bronx for 12 years. These are almost exclusively children of color. But again, my job, as much as I wanted to make education exciting and have them learn really deep, meaningful things, I think about all the skills that got us through the pandemic, whether we're talking about vaccinations, a lot of it was about collaboration and public communication about the safety of vaccines, how the scientists would work together to do it, how they would present this information. Those aren't skills that are tested. We are not assessing them. And so the very skills that got us through the pandemic are not the skills we are teaching. So I find the assessments problematic. And then again, the incentives on a school level, the schools are incentivized to teach to the tests. It's just how it is. If you can quantify it, that's what they want. And a test is easy, so they do it. And I think it's atrocious. I mentioned the garden earlier. I said it was a great gift that I was able to bring my students there. I was able to do that with ease because I didn't have to sit them in a classroom and quiz them on Regents test questions. The reason I am a teacher, or one of the main reasons I'm a teacher and was provided this incredible opportunity, is not because my loans were forgiven. I was incentivized to become a teacher. When I was in college, it was February of my senior year, a year I won't tell you what it is because it was a while back at this point. It's true. I could say at my, thanks. I've also a grown up. But my friend comes into the house. He goes, Eric, I got into the New York City Teaching Fellows. I'm like, I'm so happy for you. What is that? And the Teaching Fellows was a program which said, hey, if you teach and go to grad school for teaching in a high needs neighborhood, in a high needs subject, we will subsidize your master's. And for me, someone who always loved and valued education, I didn't always know that that was going to be the field of study I wanted to invest thousands of dollars into and maybe like the career. But being provided this opportunity to say, I have a low risk financially. I said, worst case scenario, I get a master's degree and have a good job for 2 years, 3 years. Best case scenario, I have a meaningful and valuable career. And it was the best case scenario because, as I mentioned, 13 and a half years in, a lot of students came in and out of my classroom doors. I was incentivized to go into this field. And so whether we're talking about high school students and their assessments and being incentivized to study fields, we have to borrow a phrase from our senator, fundamentally break our system and rebuild it to incentivize our students to engage in the public health field or other fields that are meaningful, and to start assessing our students and our teachers and our principals and our system based on metrics that are meaningful to what we need in our city. And when we start incentivizing more college students beforehand, not saying, oh, by the way, you want to do this, thanks, here's loan forgiveness, which is great, but incentivizing them beforehand to pull them in and say, you know what, you did really well in college, you're interested in this career, but let's pull you in and be proactive in making sure you enter this career field where we do need more people of color, more people from the communities where they will be providing healthcare to their own neighbors.
Thank you. So I will be more pointed in my question, to the chairs of the Assembly and Senate committees. What initiatives or policies related to the public health workforce are priorities for the upcoming legislative session?
So first, I do, I just want to go back to your original premise, which is that the workforce is disproportionately white male at a higher level, and I would say that's true of everything. I don't know of a field except for fields that are usually teachers or nurses that are primarily women. And even there you see a man usually emerge as the head one, right? So that prejudice is inherent. The difference, I think, here, and maybe, it's not as stark as I'm about to say, but I do think there's a difference in that with public health, you're dealing, because of things we talked about earlier, you're dealing with what no one else is willing to do, right? So usually in public health, tobacco control disproportionately is hitting poorer people, people of color more so. They're the ones that are still smoking. You see lead poisoning disproportionately hurting poorer kids. You see all those things that public health is trying to do, immunization, all of that disproportionately hurting the areas of the city in particular, but all through the state, those that are poor and those that have less access because of immigration status, color of their skin, language they speak. So what do we know about public health? What do we know about life, right? We know that if you have someone talking directly to someone who looks like them, whether it's woman, whether it's Latino, whether it's Black, whatever it is, you hear differently. You see differently. So public health is a direct outreach. And if we want to improve public health, then we have to diversify public health workers in order to have the appropriate outreach. I'm a white woman. I'm going to hear it better from another white woman, who had a similar experience. If we want to address Black mortality, we want someone who looks like that to be talking to the field, to Black women, to really understand it. So the question is, how do we do that? And what are the priorities? The easy answer is yes, loan forgiveness, but that's not necessarily going to diversify. Loan forgiveness is going to take the same people who are in the field or want to be and forgive their loans. It could, with certain other incentives, address the diversity issue, but it doesn't necessarily do it. Incentivizing, I think, is creating a program that, Eric was suggesting, which requires at the end of graduation to actually do that work. So you incentivize best, I think, by giving those incentives to people who then would be encouraged perhaps to get into the field like that, although it not necessarily either. So I think that we have to think very creatively, because diversifying our workforce is really essential to maximizing public health out there, because those are the people who are not getting the best health outcomes. So it's I think again, I keep thinking, the role that you could play as a school, demonstrating not that there is a lack thereof, but I think we're evolving into a place where we really understand that, that direct outreach by someone who looks like them, is the best outreach, but actually putting that in quantifiable terms, doing studies that demonstrate that, so that the programs that we choose as government officials have that goal in mind.
That is very true. And I'm proud to say that 65% of our students at the CUNY Graduate School of Public Health and Health Policy are students of color, and that 70% of our students are women. So just to make a statement about this. But I'll go back to the legislative session, and Senator Rivera, tell us a little.
You forgot I was over here. Yeah, I'm sorry. Yeah,
yeah,
go ahead.
yeah. So I'm thinking, like, can you tell us about initiatives or policies related to the public health workforce that are being entertained?
So if I have 10 meetings in a week and I have talking about health policy, and I talk with folks from a public health school and medical school, and then I got hospitals, and I got nursing homes, and I got PAs and whatever, each one of them, and this is something I noticed over the last couple of years, ultimately get to talking about healthcare workforce shortages, generally speaking. So it's a very complicated and comprehensive issue, right? So one of the things that I figured is that we have to approach it. First of all, it's not a crisis that's going away. It is going to only get worse. And so we have to actually try to manage it. One of the things that I managed to convince our leader that it's something that we needed to tackle, and that we needed to come up with things that were doable, manageable, things that weren't going to become, pardon my French, a pissing contest during the budget, which usually happens. So we started doing in the last couple of last month and a half, I've been doing a series of tasks of roundtables around the state. So I've gone to Syracuse, Rochester, Cortland, Buffalo, Binghamton, and obviously a lot of conversations that I have here in the city, as well as we're probably going to organize one that's going to be kind of like the last one in the Bronx that will relate to the city of New York. The goal here was to actually listen to the folks who are impacted by this, because the reality is that, and a good friend of mine, Glenn Martin, coined this term, those closest to the problem are closest to the solution. And although he was talking about incarcerated folks in that time, and in that context here, it is the same thing. It is very likely that folks who are running a public, public health school, or running a hospital, or are nurses, or are, physician assistants, or training to become a physician assistant, et cetera. All these folks would have an idea of how to actually manage that that problem. So that is just the context to tell you that I am working on a list. I don't have a list for you yet. Part of it is that I want to take all the, but I will tell you that there is definitely, from all the conversations that we had, and I mean, when we added up, probably we're talking about stakeholders in every corner of the state, somewhere in the neighborhood of 80 to 100 people, each one of them with an incredible amount of knowledge in their particular, like they run an FQHC in the middle of a rural part of the state, or they are, they represent nurses or home care workers in the southern tier, et cetera, et cetera. So there's certainly some things that we have to do about our pipeline, and I think the education piece of it is important, particularly as it relates to potentially augmenting the capacity of the full-time faculty. The notion, which is, a good friend of mine said, it's a common sense thing, but good sense ain't common. If you can, let's say you have 3 full-time faculty members doing a certain, teaching a certain group of people, if you create 3 more full-time lines, now you have 6 full-time faculty members. How many other folks can you move through the system? There are issues of funding that have to be dealt with, not sadly, but during the budget, it's going to become a fight. There are issues of certainly forgiving loans. That's a big part of it. There are issues that have to do with licensing and with practice that we have to, those are big issues that we have to deal with the state education department that kept coming up all the time. So there's a whole host of things, but I can tell you that the goal here is to create and I've also pitched it to the governor's office. So basically tell them in a couple of months, hopefully we'll come to you. And obviously, I'll be talking to my colleagues in the assembly, because the goal here is to come up with a list of things that at least take a part of it and we can actually do. And that we can actually, take, because it is an enormous issue. Can we take 3 or 4 things that we can do now that are actionable, that are feasible, that are implementable, that will actually have an impact? Those are the things I'm trying to focus on. So this side, it's to tell you that that's a long way of saying I'm figuring it out. How about that?
Well, I'm happy that it is on your list of priorities.
I'm just going to point to a couple of bills that we worked on together that directly impact the health departments. So a lot of it's when you have very little money, you look at other things, right? And we have very little money this year. So one of the things that we look at is scope of practice, and I do think there are some pieces of what the health departments do that could be done if people work to the top of their license, or whether they can employ others to do some of them. We're having some of those conversations with NYSECHO. And
NYSECHO is what?
it's the New York State County Health Officials
Association of County Health Officials.
Yes. So the other 2 things that we did get done was to change some of the regulatory requirements in this last cycle, which are before the governor, and we're negotiating now on some chapter amendments.
And
But
if you're watching, Madam Governor, please sign them. Hi, Madam. Hello.
but those are going to help workforce. Why? Because otherwise you're doing things that are unnecessary or outdated, and you're putting manpower, woman power behind them. So if you don't require those anymore, they can do something else. So there's a lot of little things like that we still, that we're looking at in a tight budget year.
Excellent. I need to alert the audience that I will be looking at questions that you may have handed to our team here momentarily. So if you have any questions, please, there are papers that can be handed out, and I will ask our panel to respond to them. But in the meantime, since you brought it up, I was going to ask you a question regarding the civil service barriers hindering the growth and flexibility of the public health workforce. How can policymakers work with the State Department of Civil Service or City Department of Citywide Administrative Services to streamline the application process, or even waive exams for public health positions? This is a real barrier, and when we have open positions, we don't have enough qualified applicants who have passed the civil service exam. What are your thoughts on this? And I will look at you as well on the screen to tell us what your thoughts are on this.
working on it. When you have an agency that's an independent agency, and like we're talking about the state level, the state education department, or SED as we refer to it in shorthand, is an independent agency that the oversight that we have of it is limited, and we have to kind of get agreement from them on certain things. So we're, but I think that certainly what has been made clear to me is that there must be changes in the way that they function, in ways that they've resisted in the past. What those are going to be, we have to get into conversations with them and see where we can get to. But I certainly feel that we have to, that there might be some places that we're not willing to go before, that I believe we have to ask them to do so.
So I've heard three things in terms of civil service barriers. First, there are the tests don't reflect what it is they're going to be doing. So they're not specific enough, or they capture other knowledge that is irrelevant. That there are some workers that should be exempted from that totally because of the function that they do. And third, and I can't speak for the city, I'm much more familiar with the more individualized counties, smaller counties like mine, that they're administered by one entity, and not there's not enough nuances for departments to take people off the lists that are generated because of the bureaucracy in terms of working with an overall arching place. I would imagine that's even more extreme in the city of New York. So those are the three things. And to address those three things, I think that we have to hear very specifically from NYSHO, now that you know all that, what that all is, what are those titles? Those titles are going to be uniform. I don't know what they are, and we haven't heard. So what are they? Number one. Number two, what are the exams that are most problematic? What's the level of workers that you're not getting? Who are they? You know, should the tests be more specific? Shouldn't it be? I don't know what the problems are. I just know that I've heard there's a problem. And three, the administration of it. And I've heard this from local governments also, like the county gives a test and then everybody's got to react to that test. They're not frequent enough. They're, you know, they'll have someone in a position for a year before that specific test is given, and then that person's out of a job. You know, the administration of the tests really needs a deep dive, and that's not limited to healthcare workers. That's something that we should be looking at. And I don't know who makes those decisions. Does the city make those decisions? Does the county makes those decisions? I don't think so. I think it's the state, but I'm not sure. But it's outside of us as health chairs. It's much more in labor, but that needs a total relook.
A quick remark from our last two panelists.
Yeah, just one other thing to add everything Amy said. We had a hearing about this a year and a half ago, just general civil service exam. And one other additional thing is that in many cases, it's months and months between when a person takes the exam and when they're given the result, offered the job, whatever the next step is. And you imagine someone who wants to enter a field, they need a job. And so it's not many people who could sit and wait around to find out if they get a job before they take another job, maybe in another field or not in the public health sphere.
So the time between taking the exam and the results.
And everything.
Yeah. Mr. Dorman, do you have anything to add to the comments that we heard about this bottleneck issue?
No, I have nothing to add about civil service, but I would like to go back to the issue of incentives and loan forgiveness programs. In our committee, we see about several hundred bills each session. Out of that, we probably see about a dozen bills dealing with loan forgiveness. And what's surprising is that we get requests for loan forgiveness from the legal profession for DAs, for rural teachers, for dental faculty, scholarship for medical students, loan forgiveness for teachers, quite a few of those, loan forgiveness programs for childcare providers. I can go on and on and on. What we don't get, and we don't have in our committee, is any kind of a loan forgiveness program for public health workers, which leads me to a bigger question. I go back over a long period of time in public health. At one time, I wore the hat as the executive director of the New York State Public Health Association. It was a vibrant time in the 80s. We were able to build together coalitions, NYSHO, Chicanes. There were health systems agencies around the state at that time. Chair of the Health Committee, Assemblywoman Paulin, was Jim Talon, who had come out of the Southern Tier as a head of the Health Systems Agency. Dr. David Axelrod was the Commissioner of Health, and Dr. Axelrod had a very strong movement for public health and the public health employees. We had a very vibrant public health association, and we built coalitions. And one of the things we were able to accomplish was funding for Article 6 under funding for local public health departments. Now, we know that the trend over the last decade has been a significant drop in supporting of Article 6 money for local public health departments. There's been a significant drop in personnel, in employees within public health departments. So again, the issue we're faced with is, one, I think it's a question of visibility of the public health movement in New York State. I think you have to have that face in front of the legislators all the time, and in the executive department and over with the Board of Regents, because really the things we're looking for are increasing the visibility of what public health does in New York State. And that requires people to be out there reminding everybody about where we are. And again, going back to the issue that I had raised earlier, I think we need to have some good numbers, some baseline numbers in place, so for us to be able to build solutions to some of the problems we're faced with. So again, if the public health community can't come forward with requests to the legislature for loan forgiveness for individuals who go into the field, that's a big piece that's missing, because so many other communities within New York State are making those requests. And I think it's incumbent upon the public health community to step up again.
Well, you're giving it back to us, and we are up to the challenge. So let's start working together on this. It's very important for us. It's very important for our students. I'm opening the floor to questions that may have come from some of our audience.
Thank you. Thank to all of our panelists, and thank you to everyone online and in the audience who's been submitting questions. One comment that was submitted was that for awareness and future discussion, NYSHO, the New York State Organization of County Health Officials, and the Region 2 Public Health Training Center are now conducting annual surveys of local health departments in New York State to enumerate the local public health workforce and identify barriers to hiring, retention, and succession planning. So hopefully the data you're asking for will soon be available. And I do believe there was a 2021 article published on the initial survey, which we are happy to share with all of you. We are receiving a lot of questions about peer support and mentoring within the public health workforce, particularly within public health agencies. As we know, a lot of burdens have been placed on them over the past few years. You saw our slide with the immense requirements on them, as well as a lot of people are leaving and institutional knowledge and experience is being lost. Do you have ideas on how to do more mentoring and peer support within our public health agencies?
I would welcome what you folks have to say about the subject. Like, it seems to me maybe that, as I said, a lot of the work that I do certainly is driven by the comments of folks that are impacted by something, and want to change something that they might be able to have ideas. The only thing that jumps to mind for me is that maybe if you're talking about mentoring, identifying perhaps state funding that could be particularly directed, and I'm completely spitballing here, but state funding that could be directed towards incentivizing, as some of the council members said earlier, uh, people actually mentoring folks within a particular department, maybe a bonus system or something like that. Is like, but I would certainly take any ideas that you have about what are some of the things that the state could do to encourage that happening.
I would just say that, so often when we think of bringing someone into a field, we think it's all about money. And we forget that, work conditions, especially with the younger generation, work conditions are so critically important and valuable to them, balancing, we read all about it, balancing work and home and all of that. And I don't think that we incentivize enough work conditions. So I don't say I have the answer. I just know that more recently I'm thinking about that. Other countries regulate, they don't negotiate individual salaries through their individual unions. They regulate salaries. So the salaries are much more across the board. And the way they steal people, is through improved work conditions. It's more competitive in that arena. And I find that fascinating. I don't know how to get there here. We have a different model, but I do think we have to start thinking about it because we see the generation thinking about it.
Thank you both. A lot of the other questions have been about pipelines and how do you see the career path for public health, particularly if you're not in a healthcare institution or in academia. How do we explain what a career path looks like in public health in a government agency or in the community for people as a way of incentivizing this is a place you can go? And then I can add on to this by talking about community health workers, or I can let you pause here and answer. Okay. Yeah, go ahead. You need my mic.
Oh, thank you all so much for your microphones. Yeah, I just go back to 60% of the workforce is white men or just white?
54% is white and 60% of the leadership positions are white.
So if I think about it, I don't know what brought all of you to the field of public health, but I imagine that at some point something got you interested, you were presented an opportunity, you saw something that sparked your interest. And the reality is, having taught in high schools, I could say that those opportunities are much more likely to happen if you are in a middle or upper middle class family, that you have more options. Part of that is, if you look at the way our schools are structured, in the Bronx, they took all of our big campuses, places like Kennedy and Walton and Clinton, and they broke them up into smaller schools. And you may be asking, what's the difference about how many students are in a school? What's the difference between 400 and 3,000? For any class, you imagine a public health class. Maybe there's an elective in public health. In a smaller school, you're less likely to have a critical mass of students who may even be interested in that in the first place. Add on top of that achievement gaps, which cause teachers like myself to, instead of being able to teach electives, we have to teach repeater courses, students who didn't pass the first time. When I went to high school, my school was 2,800 students, decent size, and very few of the students failed. And so what did we get every year? We got a book of electives, a whole book, which said, your junior science class can be electronics. It could be meteorology. Your math class, it could be calculus. It could be origami. And I'm not joking about the origami. Your English class could be Shakespeare. It could be acting. And you have these opportunities because there were a critical mass of students who may be interested in those courses. And you have teachers whose schedule wasn't taken up by repeaters. And so I think merging our schools and those campuses to have more students. And then, of course, as you mentioned, incentivizing would help the pipeline, particularly in our communities of color, where they have broken in the Bronx, where they have broken up every single high school, that's taking away those opportunities from our students.
New questions are distracting me. So thank you. The community, and I think that also addresses another point a lot of people are getting to is there's individual factors and there's systematic factors, and public health looks at systems. And you're very much talking about the systems and the communities behind the schools when you were talking about what schools get electives and choices. Community health workers are an integral part of the public health and healthcare system and are often an entry point for a diverse workforce. New York State last year, I believe it was last year, changed Medicaid so that community health workers were a reimbursable service.
You're welcome.
Thank you. I still have an issue with it.
Okay, tell me.
So you can say, I'm sorry. I'm sorry.
Because that works for hospitals
Mhm.
and health community health centers and places that are set up to bill Medicaid. But community health workers are a key part of the community health workforce at community organizations and faith-based organizations and social service organizations. So what can we do, or what are we doing to help those institutions take advantage of this so that we can cost share and increase community health workers and all the important prevention work they do?
I think we should talk about it, because I'm still a big believer in having that be a refundable, be Medicaid refundable, reimbursable. I meant not refundable, reimbursable. I think that we should have a conversation offline about how we actually, like, what exactly is the nature of these workers? How do they get paid? Who do they are? How are they employed by? To then think through how to actually potentially make that pipeline of potential funding be available to these folks. I would have to look deeper into it. How are they structured? Who are they paid by? Where exactly they work, et cetera. But I certainly would want to have that conversation again. You have a problem, a situation. We can potentially have a solution. So that's
why we invite you.
So I will say, one thing I'm noticing now, I'm only doing this it'll be almost a year soon, 11 months. But one of the things I've noticed is the outreach is not very coordinated. So you'll have the local church doing, a health fair, local hospital doing a health fair in the same neighborhood. And so to merely throw resources at all that duplication bothers me. Having said that, I see the need to do that outreach, but I do think we have to think carefully about coordinating it so we maximize efficiency within the limited government dollars that we have.
Thank you. I think we have a question that's more for the dean, actually. That's about expanding opportunities for the current public health workforce to engage in part-time education so that they can move up in their positions.
Well, obviously, it is our responsibility to enhance the capacity of the existing workforce. And we are working, for example, with the Department of Health and Mental Hygiene on a certificate in emergency preparedness. So I think we are very amenable to doing this. It has to be organized in such a way that we have enough audience for these certificates. They require attention from our faculty, and to give them the quality that you expect of us, we want to engage faculty with experience that are able to provide this level of instruction. So it has to be coordinated with government agencies or others, where the audience that participates in such cohorts, and we can create them as cohorts for an identifiable period of time. Like you can complete this certificate by taking 2 courses every semester within a year. And we will dedicate the faculty required to produce high quality courses. But obviously this is a cost to the school and can only be practical if we have enough of an audience to fill these classrooms in such a way that it becomes feasible in a practical way. But we are very, very responsive to this need as the public school of public health.
I love that you said certificates. So we've had a number of hearings on the Higher Education Committee, including joint hearings with the Economic Development Committee and the Education Committee, which is K-12. And I love that you spoke about certificates. And, you know, we talk about other things like micro-credentials. And I just imagine a world where a high school student or someone who graduates college, maybe they're in college, maybe not, but could get something tangible, a certificate. And so I'm talking about earlier in their career path. And, you know, you go into the school and then you say, what kind of students am I going to recruit for graduate school or for school? I'm going to look for those students who already have a certification in something or already have credits in something. And that's where health professionals and schools like yours going in to the high schools and providing, again, those incentives. It's all well and good to have something listed on your transcript. It's better if a student can walk away with a piece of paper or something they could present to a potential employer and get a leg up on getting into that career, getting the other training courses they need, getting into college ahead of the game. Saves them money, by the way, because college is, as we know, expensive. Saves them time, and again gives them a leg up in getting into the profession.
Thank you for expressing it in very practical terms. And I would say that certificates such as this are valuable if they are coordinated with the employer, meaning that they respond to specific needs of the Department of Health, of local health departments, etc. So not a pie in the sky where we sit as a group of faculty in an ivory tower and come up with a certificate. But in those terms, the other element of it that's very important is that it is credit bearing. So if it is a credit bearing certificate, you can use it eventually towards a higher degree rather than being an isolated certificate. Now, the value of an isolated non-credit bearing certificate is that we as a university can cost it in whichever way we want. If it's a credit bearing certificate, it has to respond to the per credit tuition that the university has. So these are all permutations and computations, but in principle, to whomever asked that question, we see that as our role, not as a fringe component of what we do. And we are beginning, we created a general certificate in public health that is credit bearing that found a very good audience so far. And now we are looking at a new certificate in emergency preparedness.
But if you're just from the city perspective, right now, the mayor presented a November plan which severely cut almost all of our agencies, including education, the Department of Education and CUNY. And in those cuts would include our early college programs, which are few and far between, but they exist and they are extremely successful in narrowing those gaps that were mentioned earlier. So if I would recommend doing another form of advocacy besides health advocacy is political advocacy, and saying that the cuts to our education department and the cuts to those early college program, which the city pays for those credits. So the kids aren't on the hook and CUNY's not on the hook for this money. It pays for them to get that leg up, to get those credits and to get those certificates. Those programs are on the chopping block right now because of the cuts the mayor has proposed. So I'm just going to highly recommend reaching out to your local elected officials, reaching out to the mayor and saying that the cuts to these programs will be detrimental long-term to the field of public health.
Sure, and I'd like to make a distinction. We have a lot of such programs in our community colleges. LaGuardia Community College, for example, has a host of such training programs. We are a graduate school of public health, So we don't do a lot of undergraduate work.
Well, we fund in the city, the
Yeah.
community college.
Correct.
I mean, we're talking pipeline.
Of
pipelines
course.
are a month.
No. I'm totally 100% behind you. I'm just making a qualification. That's all.
Okay, I think we have time for a last question, which feeds off of what Councilmember Dinowitz was just saying, which is that, you know, our graduates luckily have a high rate of employment, but we know that there's a huge vacancy rate at local health departments. We know there's budget constraints. We know the November plan that the mayor proposed has a huge number of cuts to all city agencies. We know things are going to be tight at the state when the budget plan comes out. I'm not just picking on the city. But so going into all of this, how do you prioritize the myriad critical needs that you're facing? You know, there's public safety, there's education, there's health, you know, there's Rikers in the city, there's affordable housing. What's the calculus in your heads? How do you prioritize all of this as you go into these conversations?
So we're the health chairs. That's an easy thing for us. We prioritize health. That's our goal. That's our responsibility. So we will be fighting, and I know I can say this for both of us, we will be fighting for every single program that the governor cuts. We assume there'll be some cuts, just like we saw the mayor cut. It's tight times. So we will be, so all those other things, this one's first for us. Am I right?
You are correct, and I would add that part of the work that we're doing, and then I know that we will do, and now some of our colleagues in the council are doing it, is to point out how boneheaded some of these cuts actually are. And the
Tell us
fact
how
is,
you
like,
feel.
oh, trust me, I know this is going out over the intertube, so I'm making my staff very happy by not doing what I usually do when I talk about my good friend the mayor and other things. So what I would say is that we're one of the things that we do is to try to point out there are other options. There are places where cuts are going to be much more painful. And one of the things that I talk about constantly, certainly in the health field, at the state level, is that we should not think of them as expenditures. We should think of them as investments, because the reality is that there's so many places where if you don't spend the money now, you're going to be spending a lot more money down the road. I mean, certainly it's not necessarily related directly to your question as far as public health, but just quickly, Medicaid rates and the fact that healthcare institutions, particularly safety net institutions across the state, which serve the most vulnerable, are the ones that are most in need, are the ones that get cut, that don't get sufficient funding. So everyone that walks in the door, they're already in the red as soon as that happens. And yet those institutions are going to come back to the state and say, like, hey, we're going to run out of money in 3 months. It happens all of the damn time. And we're saying to the state, do you not see that this is what's going to happen? So how about we invest the money now so that we don't have that, which is going to be worse down the line. And certainly, again, the boneheaded, for my communications director, very PG, the boneheaded cuts that are happening at the city level do not, like, they're worse than just cuts. They're actively hurting the folks that are the most vulnerable, and we can't let that happen.
Absolutely. I think you just described prevention, which is something we talk about a lot in public health, and that $1 spent on prevention saves 60-something dollars in treatment and costs later on.
But, you know, I just want, before Eric speaks, you know, COVID is the example. People criticized every aspect of the response. I mean, there was very little praise that I can remember. So if you want to make sure that we're prepared for a catastrophe, hopefully not to that level, then you have to do that investment, as my colleague said.
I think one of the challenges is we sort of lead like with our hearts and with our morals and values as to what's right. And we know it's the right thing to house people and to keep everyone healthy. But when it comes down to it in New York City and state, we have to have a balanced budget. And so I think the way the senator articulated it is absolutely correct. Not expenditures, but investments. And when I sit on the budget team in the city council, And one of the arguments I make, whether it's in the closed doors or at the hearings, is what do our investments get us? One of the programs I've been focused on is a CUNY program. One of them is called ASAP. One of them is called Reconnect. ASAP is a program. It's a sort of wraparound services for our college students that keeps our community college students in school. ACE has that for our four-year colleges. And Reconnect reaches out to people who have some CUNY credits and brings them back to college to get a degree. And you look at the numbers, the small, we're 5.8 million this year. We're investing in CUNY Reconnect. That is on the chopping block. We'll bring in $1.9 billion in lifetime earnings of the people it brings back in. ASAP's, it's well studied, the ASAP program, which again, they should just call college because it's supporting their students' needs. But the return on investment for the taxpayer is according to between $3 and $4 per dollar invested. And so I think that though the dollar figures, it doesn't take away the importance of the value of educating someone, of the moral imperative to educate people and to house people and to keep people safe. But when we're talking about a budget, it has to be balanced. We can't spend more than we take in the city and the state. It's different in the federal government. They invent money. We can't do that. We can't do that in the city. And so critical to our work is looking at those returns on investment and looking at that data. And that's something that I, at our budget hearings in the rooms, am constantly bringing up to show that they are, what kind of cuts? What are they?
Boneheaded.
Boneheaded, because they're not smart and they're not fiscally responsible. We are cutting programs that bring more money in over the short and long term, and they are boneheaded.
And we have to raise taxes on the wealthy. We have to do it at the state level. We have to do it at the state level. We have to do it at the state level.
Jan, do you have a last comment on this that you want to get in before I give it to the dean to close us?
I'm good.
Well,
I appreciate
not
the
a
comments of the
boneheaded person,
panel
yeah.
members.
thank you all for such a vibrant conversation. We like to end on time because we know your time is very precious. And we want you to leave the session today with your hearts full of love for our school, for our students. We contribute all we can towards the future of public health and the public health workforce. We're very proud of our close to 1,000 graduate students, almost 800 master levels, and the largest doctoral program in public health in the city of New York, funded by the taxpayer of New York. Our students know that. We are intent and constant in providing a high quality, low cost, accessible education. And your advocacy for us and towards the public health future in the state and the city of New York warms our hearts. And for that, we thank you all.